Let's talk a bit today about how I see the body differently than most clinicians, nearly all, if you will, in mainstream orthopedic medicine. And that is, I think it comes down to kind of lenses. I mean understanding, but when I look at the body, what is my lens? What am I seeing? I think mainstream orthopedics focuses not exclusively, but a lot on the anatomy and physiology of muscles, and then the anatomy of structures, meaning is there structural competence in ligaments, labrums, menisci, cartilage, bones. And they do also focus on nerves, but to me it's like muscles and structures are everything, and they're not really thinking about the physiology, the function, the movement of joints, and that boils down to mechanics or biomechanics. And we definitely learned about kind of joints, obviously, in our doctoral studies. I remember learning the different grades of joint mobilizations, but when I learned about how to mobilize joints, I was thinking the purpose was reducing pain, which, lots and lots of things reduce pain, so it's not very cerebral. And then we were thinking about mobilizing as stretching capsules and kind of just facilitating stuck movement, which I think is the most appropriate to what is germane with how I kind of see the body now. So my lens is different because I see pathoanatomy and pathophysiology of muscles. I see pathoanatomy of structures, but my first glance, my first thought, because of prevalence, of course, is how is the joint working, or how are the joints working if it's more than one? And I'll give you kind of some examples about just normal things, right? So even take away doctors and clinicians, think about just the average person. I think they've kind of not bought into, but because they've been taught so much about muscles and structures, that's what they see. That's their lens. That's what they think about when they think about exercise, when they think about injury, and when they think about treatment. So take this example. Someone warming up for a basketball game or even warming up to run. Many times they're going to be doing some dynamic or static stretching. And I'm not going to get into the pitfalls or benefits of those things right now. I'm just going to talk about different understandings of what those movements are. Let's say they think they're stretching, which they are. So maybe there's toe touching, which is hamstring stretching. Maybe there's kind of bending over and leaning side to side with your leg kind of at a hurdle, or splits to stretch the adductors. Maybe you put your hands against the wall and you stretch your calf muscles. Maybe you sit down and you do the butterfly stretch, getting more adductors again. You might possibly grab your heel, bring it to your bottom, and do some quad or hip flexor stretches. But just thinking about those, we can name them as stretches if that's the goal. That's fine. But what I also see, usually what I see first, because muscles being tight is such a rare phenomenon that causes pain and dysfunction that makes people seek medical care. If we go through those, so touching your toes, hamstring stretching, sure, possibly. It's also tensioning the sciatic nerve, but for me, in the joint mechanics lens, it's lumbar flexion and hip flexion primarily. Yes, other joints are involved, but that's the primary movers or primary joints involved. So lumbar flexion, hip flexion. In that kind of splits stance where you're bending forward and going to the side to get the adductors, you're also getting lumbar flexion and hip flexion. You're getting knee extension, yes, other things, but let's focus on the main things. In the leaning against the wall, doing the calf stretching, usually the low back is bent, so you're getting some lumbar flexion and or hip flexion. In the other example, the butterfly stretch, you're sitting, that's a lot of lumbar flexion for most people, and some hip flexion and external rotation. And then if you're doing the last one, which is a quad stretch, bringing your heel to your buttocks, some people bend forward with that, some people are erect, so it's either the lumbar spine is in neutral or the lumbar spine may be flexed. So again, I'm saying this is not good nor bad. This is just the lens. So if someone had a problem and their warm-up was all those things, I'm also considering, in addition to the tissues that they're stretching, what is their lumbar spine doing? What is their hip doing? What is their knee doing? What is their ankle joint doing? Because we're not really talking about the upper extremities or the upper body in this scenario. So I think that lens is missing. And that also applies to exercises like a squat. I do barbell squats. I think squats are wonderful for a lot of people. They're a great lower body strengthening exercise. But I'm not just considering, is it working quads, hamstrings, glutes? I'm considering how much lumbar flexion is going on, how much hip flexion is going on, maybe thoracic flexion. I'm considering that the exercise the point of the exercise is to attack and strengthen muscles, but the joints are doing something. And the mechanics of the lumbar spine in a squat, I think, are very important because there are lots of people who get into trouble in their low backs with squatting repetitively or squatting high amounts. And it's not necessarily the squat, right? Because they could be sitting in lumbar flexion for 8 hours a day, and then that's just the icing on the cake is doing heavy squats in lumbar flexion. But we must consider that joint mechanics, joints are doing something in that movement. And another example that comes to mind is I had a patient who was a runner. She was having some lower extremity symptoms. I forget if it was her hip or her buttocks or her calf, but she was okay if she ran from her house, went for a run, out the door, came back. But if she drove to the park or the beach and did a run after 20 to 25 minutes of sitting in her car, she was symptomatic at the front end of the run, and it got better the more she ran. And to me, thinking about the lens of joints, that was clearly a joint issue. I mean that the likelihood of that being a joint problem in the lumbar spine or possibly the hip was just so strong because of that difference, right? I can just be at home and go for a run and fine. I sit for 25 minutes, likely in a bucket seat. I remember we implemented a car seat wedge that was helpful, and it was her lumbar spine, but she was in so much lumbar flexion for 20, 25 minutes, and then getting out of that, getting into a neutral to extended lumbar spine position with running was creating the problem. So again, that lens, I think we need to think about the things that mainstream orthopedics think about, but we need to also think about, well, what is the joint doing? And it's not necessarily the joint where the symptoms are. Like I said, I forget where her symptoms were, but say they were in the right posterior leg, what people would call the calf, but I would call the posterior leg because I don't name body parts based on the muscle there. I name body parts based on the body part. I think that comes from, again, people understanding the body through the idea of muscles and structure. So you just name the muscle or name the structure. Whereas if you named it by the body part, I think you would have less of a kind of predilection for blaming a muscle or a structure. So the calf, the posterior leg can be where the symptoms are, but the affected joint could be the lumbar spine or the hip or the knee. So the affected joint is not always at the location of the symptoms, because mechanics in one joint can throw off mechanics in other parts of the body. And mechanics in joints of the spine can, the discs in particular, we know that they can refer symptoms. And then if it becomes a different problem, a different pathophysiology where now the disc is hitting a nerve, then that becomes kind of nerve pain, and that's what we call radicular pain. So I think if there's three kind of avenues in which mechanics in one part of the body can present with signs and symptoms, maybe local, but also or distant from the place of the actual problem. So having this lens on how the body works is obviously not going to be helpful if you don't have a solution, right? If you just understand like, oh yeah, I totally understand that squats are not only working the lower extremity musculature, but they're also putting my body in lumbar flexion and hip flexion and knee flexion and ankle dorsiflexion. If you don't understand, well, maybe the solution is looking at a movement other than those movements of the joints. Not always, but if someone gets worse with lumbar flexion that they do repeatedly, the thought process for me is maybe they do need more lumbar flexion, but it's more likely that the joint needs to get back on track, not with taking them to end range flexion, but taking them to end range extension or side glide or rotation and flexion or any number of movements. The joints in different parts of the body have different types of movements. But if you don't have a solution, then having that lens is not very helpful, because if your solution is, well, just don't do flexion, that's not helpful. We maybe temporarily, as we let the joint heal, the mechanics restore to normal. But over the course of our lifetimes, we want to be able to do these things that are within the realm of normal, that are within the realm of appropriate biomechanics and load on the body. If we have a solution where, for this squatting example, if someone's sensitive to lumbar flexion, maybe it's reducing the 8 hours of lumbar flexion this person's putting through their low back when they sit at their office, or maybe their car is especially bucket-like, and we want to get that flexion reduced and make the lumbar spine more neutral in driving. It's really individualized to the patient. But the solution is thinking about, okay, if this joint movement is problematic, what do we need to do to this joint, not to the muscles? What do we need to do to this joint in terms of movements repetitively or positioning repetitively to, like I say, get it back on track? And I think that is a perfectly kind of nice way of putting it, is that that's what we're doing. We're getting those mechanics back on track. This is a problem of pathophysiology. This is a movement function problem. It's not a problem of a piece of your body being incompetent, a piece of structure, a ligament, a muscle, a cartilage being incompetent and not being able to do its job. It's competent, it's structurally sound enough. Maybe on imaging we're going to find some stuff because that's normal, but it's sound enough, but it's just not functioning well. So it's kind of like the same thing with, non-orthopedic medicine, is if someone has disparate symptoms and signs and the doctor's lens is, I need to cluster these things together and prescribe a pharmaceutical treatment, that's one lens. But if the other lens is, let me cluster these things together and see if there's a vitamin or mineral deficiency that would kind of line up with this, and that would be our prescription. That would be the medicine, is just increasing dietary intake of that specific deficiency or supplementation. So if you don't have a lens for joints, if you don't really see the body through how joints are positioned or moving, you will miss that as a possible diagnosis. That only makes sense. And if you do have an understanding of how joints work, like walking is not just working your heart and working your lungs and working your lower body muscles, it's also extending your low back more than in sitting. It's also extending your hip more than in sitting. then you can start to appreciate, well, maybe the person's knee pain in walking is due to the position of their lumbar spine or their hip or their knee. And it's not just a muscle thing of the knee or not just a loading problem of the knee, wherein walking puts a load through the knee. So Robin McKenzie's work is what kind of gave me this lens prior to understanding his contributions to orthopedics, which is a test called repeated movement testing. And repeated movement testing will tell you if the joint is the problem, and if it is, you will apply the specific repeated movement that the joint needs. So his contribution was the test and the solution. Before I had this kind of understanding, I was treating kind of like what mainstream orthopedic care is right now. I was really focusing on strengthening muscles, stretching muscles, sometimes lengthening nerves via flossing or gliding, also thinking about structures, and then these kind of weird, vague clusters of problems that contribute to syndromes like IT band syndrome, where we're trying to do lots of different things, or shoulder impingement syndrome, which means we're doing lots of different things that I now reject because they are convoluted and not really borne out in the literature. Whereas if you find a joint that's the problem, it can be creating all these disparate signs and symptoms, and just getting the joint moving well again by repeatedly applying the movement that one particular joint needs will have all those signs and symptoms abate, which proves to me, since I've been doing this now for years, that all those times that I was applying 8, 9, 10 different things, they were unnecessary and inefficient and more complicated than it needed to be, because the problem was likely, if I went back in time and reevaluated those patients at that time, the problem for them was likely a joint problem. Joint derangement is what we call it if the mechanics of the joint can be fixed with a specific movement and signs and symptoms abolish. And that's what I find now, using this lens. I find that that's about 70 to 80% of orthopedic disorders. Yes, there are structural problems, usually with trauma. Sometimes there are muscle problems, but again, I don't really believe that there are many people who have pathologically tight muscles for no reason. There has to be, in most cases, a very obvious reason why your tissue got tight, such as being in a cast for 6 or 8 weeks. So in closing, I think a big difference, or the biggest difference with how I approach the human musculoskeletal system compared to most clinicians, is that I'm considering the mechanics of joints, which is physiology, first and foremost due to prevalence, in addition to considering pathoanatomy of structures or pathophysiology of muscles.